is going to be a global burden. I'll just give you a very simple uh, images where you'll enjoy all these next 20 slides are going to have a beautiful images where you will have a print in your mind that this is really going to be a big, big burden to all those youngsters who are sitting in this hall. This is going to be a global footprint in coming years. It's a big number which you are going to see across the globe. Everywhere there will be diabetic foot. So there is going to be a burden of a number. There is going to be a clinical presentation burden. Amputation is going to be a burden. Footwear science is going to be a burden. Exercise. And am I going to cure this? Am I going to cure this disease or no? This is going to be a burden. The disease started, the first conference on diabetic foot was started in Melbourne in 1986. Since then till now, it's a 3 decade. What knowledge we gathered and what was our mission? What we did well in last 36 years? We did well, we could understand that diabetic foot is a common condition, it is a complex condition, and it is a costly condition. What else? Recurrence, relapse, failures are maximum in best of the best centers in the world. Not only in India, everywhere across the globe. This we understood in last 36 years. There are 2 types of evidences in diabetic foot. One is a clinical, another is radiological. Normally, when you open an abdomen and do the stitching and remove the stitch 7th day, the wound has healed and you are happy. No. Here in the foot, you have to have a radiological evidence. Once you have healed a wound in the foot, after 100 days or after 60 days, you have to take an X-ray. That bone is not involved in that. If there is no osteomyelitis in this due course of your healing process, then you are right, you have done a good job. What didn't work in last 36 years? We are unable to prevent the first ulcer. We are unable to prevent. Entire globe is unable to prevent the first ulcer. We are trying to heal. I think I met some of the young PGs in surgery. They are working on this, healing an ulcer. A lot of healing process is going on. But once it is healed, prevention of recurrence is not possible yet. 60% are getting recurred in 1 year. So these are not yet our achieved goals yet. So we are struggling hard. We are struggling hard in which segment? We are working more on healing of an ulcer. We are not working on number 1 and number 3. So in 1986, everything started. There is one more event happened. 5-year targets were given in 10th to 12th October 1989. That is called Saint Vincent's Declaration. Have you heard of that? Anybody has gone through this Saint Vincent Declaration? Europe had maximum diabetes patients. So they decided a problem of all ages in all countries, a model of prevention and self-care. Saint Vincent's, a meeting organized by WHO and European Association. And whatever the targets, these were the targets which were decided. Suppose in Uttar Pradesh, you decide in 2023 that I am going to take care of diabetic foot, then within 5 years, the reduction should be of amputation more than 50%. That's the target. That is how the target was set in. Reduce new blindness, reduce number of people entering end-stage renal disease, reduce by 1/2 the rate of limb amputation for diabetics. These are all the targets which were sent in St. Vincent's Declaration. And everyone has to work on these lines to bring down all these complications, comorbid conditions of diabetes. Now let us look at the burden number. What is the global number? You can see a big, big number. You can see 537 million adults are with diabetes. 3 in 4 are in low-income countries. 6.7 million deaths are due to diabetes. Now let us go to Southeast Asia. 90 million. 1 in 2 are undiagnosed. They don't know that they have a diabetes. 747,000 die because of diabetes. Number of adults is going to increase by 113 million in 2030, and 2045 it is going to be a huge number. At present, do you know how much we are spending on it? We are spending around $10 billion. $10 $10 billion has been spent on diabetes in 2021 in India. Now let us work on Indian scenario, what it is. It is latest approach 101 is a big number. More than 50% are undiagnosed and huge number are dying because of that. And this is a scenario, what you should know in 2021, the expenditure, what has been done on the diabetes and foot per person, what all problems are there. And look at the figure, which is escalating to exactly more than 50% by 2045. Uttar Pradesh. If I place Uttar Pradesh as a country, it stands number 8 out of 224 countries in the world because of its population. It is 20 CR. The next, which is Brazil. So Uttar Pradesh is 8th country by the population. But if you look at the diabetes scenario, if I take 10%, 20 million are diabetic, more than 50% are not aware that they have a diabetes, and 1/5 of 6.47 are dying because of that. Now let us come to Lucknow. Lucknow, as I went through the search, it is 50 lakh population. Total population of Lucknow, 50 lakhs. 5 lakh, 10% if you take as a diabetic, 5 lakh are diabetic already moving around here with a prick. With a prick, they are diagnosed as a diabetic. Into 2, every diabetic has got 2 legs. 10 lakh limbs are at risk. Out of that, 2.5 are already with ulcer. Already they are moving with ulcer. They are going doctor to doctor. They are attending so many doctors. It is not healing, sir, kuch alag do, ye heal nahi ho raha hai. So there are 2.5 lakh already ulcers are moving in Lucknow. Out of this 2.5 lakh, 25% are getting infected very badly. And out of this, 50% are getting amputated, admission and amputation. It's a big number. How many of you know Charcot foot, neuroosteoarthropathy? The incidence, the prevalence is 1 to 10%. If I take, when you focus on picking up Charcot every day, you want to observe it, then that one of the study has said they have got 10% recurrence. So I calculated 10 and I have in Lucknow more than 1 lakh Charcot. More than 1 lakh Charcot if you take 10% into that. So it's very important that you are with a huge burden of Lucknow itself with a high risk feet. How many doctors are there in Lucknow? As per the WHO recommendation, 1 doctor per 1,000. If I calculate in that fashion, there are 5,000, but it doesn't happen. It doesn't happen. It may be less than that. Even if you take 2,000 doctors or 2,500 doctors in Lucknow, look at the number, the way they are seeing the patients every day only on foot. It will be a huge burden in coming years. So it's going to be a big challenge. There will be too big to cure. What are the clinical presentations? Every patient will come to you and tell, sir, wo sab baad mein dekho, sugar वगैरह, mera paun dekho sir pehle. Look at my feet first, whether it is going to be amputated or it is going to be saved. This will be a direct question a patient is going to ask you in coming years. Every 1.2 seconds, there is an ulcer. So there is going to be a big risk, life as well as limb. This is what we have: a pre-ulcerative, ulcerative, non-ulcerative, active disease, and chronic disease. These are the common presentations in diabetic foot. We have neuropathy, neuroischemic, ischemic, critically ischemic, acute ischemic. Recently in COVID time, I think you might have seen a lot of limbs we received in our place with acute ischemic. Many patients had got. Non-ulcerative, skin department is flooded with so many cellulitis behavior, necrotizing fasciitis, blebs. They enter always dermatology department. But it is a very bad presentation. And we have ulcerative, where there is an ulcer, we call it as DFU. If it is osteomyelitis, we call it the DFO. And if it is infection, we call it the DFI. So look at, in these varieties of combinations, you have got Again, a most dangerous zone. Renal foot, cardiac foot, HIV is no more an acute disease. It is a chronic disease now. HIV and diabetes and diabetic foot. Double trouble. We had many patients like this. We saved the limb, we saved the life. And we saved all our nursing staff who are working on wound care division because we don't want them to get exposed to the dressing zone. So we had different techniques. Pemphigus, acute emergency in skin with diabetes and diabetic foot. Blebs, how to prevent it? Necrotizing fasciitis. Psychiatric patient, diabetes, diabetic foot. हर 10 मिनट में पानी जाके डाल रहे हो ऑपरेशन करने के बाद पांव के ऊपर. How you are going to heal the wound? I operate, I admit, sister calls me, sir, patient bathroom washroom गया है, पांव पे पानी डाल देंगे. 10 times a day they are doing this. Imagine how the changes are going to come up in coming days. CLTI, critical limb threatening ischemia, which is going to be a big burden in coming years. But this is going to be the next 10 years. Everyone sitting in this hall are becoming a well-known surgeons. They are going to take out great toe, second toe, third toe, half of the foot. And इसमें बड़े तादाद में लोग आएंगे यहाँ पे. पूरे लखनऊ में और पूरे भारत में सिर्फ हाई रिस्क फुट रहेगा. आपको कोई टेस्ट करने की जरूरत ही नहीं पड़ेगी. आप जितने टेस्ट लेके बैठे हो, न्यूरोपैथी असेसमेंट है, वो असेसमेंट, ये असेसमेंट, सिर्फ यही पाँव लिखेंगे आप. This is going to be a big burden in coming 10 years. I want the youngsters to know the first amputation below knee done by Ernest Bergman in Berlin in 1901. Yeah, about high-tech OT, hybrid OT. So many high-tech lights, tables, procedure has remained same. Nothing has changed. Nobody is working on how to prevent amputation. So, look at the number. Everyone is interested in this artificial limbs. This is going to be a big burden in coming years. Every 22nd, somewhere, some part of the globe, a limb is amputated due to diabetes. By the time I finish, if I take 20 minutes, 60 limbs are amputated somewhere, some part of the globe. This is a basic module, diabetic foot care module. The moment somebody is having diabetes, you are having a normal day of care. People look at diabetes, diabetic foot when there is an ulcer, when there is an infection. No, the day you are having diabetes, that foot is diabetic foot. Please make these points very clear. There is an ongoing process, neuropathy, vasculopathy, all these are ongoing process. End product of glycation, whatever is there is getting deposited in all the tendons and it is becoming rigid. There is a PNP PVD care, peripheral neuropathy care, vascular care, there is an ulcer care, there is infection care, and your patient come to me today, they have lost one limb, they come to me, sir, prevent my other limb from amputation. So rehab. So this is going to be a big workup, rehab care in coming years. But this module, the basis of this module is to prevent an ulcer and to heal an ulcer or to have a rehab footwear care. If you are not having this footwear care, knowledge, new science, understanding, you miserably fail in handling the diabetic foot. Even to prevent ulcer, normal foot should not have ulcer, you should understand what is the footwear science. And if it is ulcer, after surgery, infection, rehab, you need to have footwear science. So it's very important that all of you should make it a point to understand footwear science. This is a risk stratification. We see that every patient is categorized. Zero risk, risk number 1, 2, 3. So who is in high risk? The one who has loss of protective sensation, PAD, or one of the following, a history of an ulcer or amputation, or CKD, chronic kidney disease. All these straight away, CKD may not have an ulcer, but straight away he enters into high risk. So you need to work every month this patient to attend you and pick up the how it is going through. In India, the most important, very high risk, what I look in my practice, because I'm working on a rural segment, very high, barefoot walk or not walk. I keep on shouting at my patients, don't go barefoot. So they come and tell me, sir, आप बहुत गाली देते हैं इसलिए मैं shoes पहन के आया हूँ. That is worn out footwear. That is more dangerous. That is more dangerous in diabetes. These two entities have to be addressed across India. And I know in Uttar Pradesh, the popular footwear, what it is. It doesn't fit for the diabetes. So you need to understand what should be recommended to the patient. Footwear science to prevent first ulcer, to heal ulcer, and to prevent recurrence. Yes, we need to work on this. But the most important question you need to address, when to buy the footwear, diabetic footwear, when to buy. What is the life of the footwear? कितने दिन चलता है सर वो footwear? Not more than 3 months. Not more than 3 months. Make it a very point. In India, the concept is जूता फटने तक मेरा ही है. बिल्कुल नहीं चलेगा. The moment insole is out, 9 mm से 4.5 बन गया. You have to change the insole. If you are not changing the insole, you are coming back with ulcer. So I convey the message to all my patients. If you don't invest for insole 100 rupees, you are going to spend in 1 lakh rupee in few months. You have to do that. Maximum 3 to 4 months. Why, sir? Why it is happening like that? Why patient doesn't have lifelong or 3 years, 4 years approach to the footwear? When they have a neuropathy, the foot hits the ground very bad. There is no control at all. So when the foot hits the ground, the outer sole, the inner sole is worn out. When and what to replace? Seam or seamless footwear. Always prefer seamless footwear. Never go with the footwear which has got designs. I could see Professor Gyan today, his footwear is seamless. Absolutely, there is no seam at all. So that kind of footwear. But again, I was not happy because he is not diabetic, but broad. I don't want Jitendra style footwear. No, we would not recommend for any of the diabetic. No narrow forefoot zone. It should be a broad forefoot. Always look at footwear, very important. What to not to prescribe is very important. What not to prescribe is very important in your practice. Sir, मैं लखनऊ में नहीं हूँ, तहसील बहुत छोटे गांव में हूँ. How I should practice? I don't have resources. Then footwear in limited resources, you should know how to recommend. It is not like if I say something in a guideline and protocol that this has to be given to the patient and patient can't reach to it. Then you need to understand that situation. Now, how best I can bring up a footwear in limited resource. Exercise. Everyone wants to know regarding power of exercise, and everyone diabetologist keeps on bombarding that you should walk 2 kilometers, 10 kilometers, jog, jump, run. Well, this is what is recommended. Please remember this chart. Low risk, 10,000 steps. हर बंदा अपने मोबाइल में देखते रहता है. मैंने 8,000 कदम चले, मैंने 10,000 कदम चले. No. Diabetics should not do this. If you are a low risk, you are alone. Otherwise, you have got so many options. There is a swimming, there is a static cycle. Keep in mind. If your foot is medium risk, not more than 5,000 steps. If it is a high risk, the big question mark I have placed there. Not 1,000 steps per day. It is going to break. If you are hitting the ground repeatedly like that, and patient come and tell you, sir, मुझे सर ने बोला है शुगर कम करने के लिए चलना ही है. Wrong. Very wrong. He has to go for swimming or static cycle as an exercise. Now, the issue is, the challenge is, when you treat a foot for an ulcer, infection, and charcoal, whether he should walk or he should not walk. He should have maximum rest and reduce the number of steps because, can you see this? It heats up. Every foot, when it hits the ground, it heats up and it cracks. So there is a temperature which is there in the foot. So always remember all these during COVID time, you have got all the temperature recordings with you now. Every foot, you can check the temperature at most important pressure point level. If it is increased, tell him, देखो भाई अभी ये फट जाएगा, यहाँ पे जख्म होगी, आप रेस्ट ले लो. This is how every foot you can prevent from by checking the temperature at different levels. No walking, no jogging. Anybody is having this, don't recommend any kind of walking, jogging, no exercise. Next, Charcot foot, deformed foot, no walking, no jogging, nothing. This is a challenge. I don't know how many of you are seeing this. I am seeing daily in my practice. Bilateral diabetic, which I told, I think Dr. Jan may be recollecting. 7-8 years back in one of the conferences, I had told this. This is going to be a new challenge to all of us. What you are going to suggest this man? How to take his body weight? यहाँ पे डालोगे, यहाँ पे फटेगा, यहाँ पे डालोगे, यहाँ पे फटेगा. And this is going to be a big number now. And I am already having this. You can see these two guys are sitting in my clinic. And this is what is going to be a new challenge. The doctor has done a surgery for good, but it is not healing. There is already something he has done it, still it is not healing. All bones are deformed. So you have to plan functional limb salvage surgery, deformity correction surgery as a specialty. And this is how you are going to give, I am biomechanically viable foot. Same foot after surgery has come back on. So you need to develop a new science, which is going to be a big challenge now. Now, what is the new prescription? Everyone is interested. Patient comes and asks, sir, जख्म भरने के लिए बहुत बढ़िया दवा ले लो, इंजेक्शन दे दो, कुछ ना कुछ गोली दवा लिख के दो. No, there is no tablet or anything for him to heal the ulcer. The new prescription is number of steps per day. You have to write in the prescription, आपको 100 कदम ही चलना है रोज का, आपको 200 कदम ही चलना है, then only the ulcer heals. Otherwise, no, you can't write any medications for the ulcer to heal. Number of steps per day is going to be a new prescription. This I specially brought is a big challenge now, as we are all working on AMR, antibiotic resistance now, which is going to be a big week now everywhere across India, people are working on. The moment somebody sees an ulcer, क्या ले रहे हो आप? Ciplox ले रहे हो? नहीं, we will give you Dionam. Dionam बहुत बढ़िया है, उससे जल्दी heal हो जाएगा. People keep on changing, doctors keep on changing antibiotics after looking at an ulcer. Wrong. Please shoot an antibiotic in a DFU if it is infected. What is the sign of infection? Local swelling or induration, erythema more than 0.5 centimeter, local tenderness or pain, local increased warmth, purulent vista. इसमें के 3 तो रहने चाहिए. Don't simply looking at the ulcer, don't shoot the antibiotics. So, what is the mantra? What mantra you have to chant every day? No clinical sign of infection, no infection. No infection, no culture. No culture, no antibiotics. Don't send unnecessary culture. They are all commensal. There are no infective organisms there. So never shoot antibiotics unnecessarily. What has happened in last 10 years? I've been working in this field for more than 25 years now. In last 10 years, I am receiving every diabetic foot of the MDR, multi-drug resistant. I don't have any drug at all in my hand. I have AK-47, no bullets. Absolutely no bullets with me. This is a very bad situation what we are reaching now. Yes. The moment there is a DFI, again everybody is having a challenge. Everybody wants to hit at the tail of the snake. You need to hit at the head, then only you are doing a right job. So, if it is an acute DFI, where he hasn't gone to any doctor, he has come back straight away to you, then if it is a neuropathic, it is always gram positive. If it is ischemic, always gram negative. If it is neuroischemic, always gram negative. Plan it till you get culture-specific report. If it is a chronic, it is always gram negative. Till you get culture-specific. Start antibiotics in this fashion. The big question. Most of the doctors, they claim the moment patient comes and tells, sir, 2 साल से जख्म है, और वो जख्म नहीं भर रही है, आप मुझे उसको ठीक करके देंगे? हाँ, आई एम गोइंग टू क्योर इट। नो, प्लीज डोंट से दिस वर्ड इन डायबिटिक। There is no cure. There is only arrest. You are going to arrest the disease process. As long as he is going to walk, he is going to break his feet. Remember this. Never ever say that I am going to cure you. I am going to arrest the disease process. So फिर success क्या है? What is success in diabetic foot? Keeping patient ulcer free for more than 5 years as cancer. You have kept cancer not to recur. You are successful. Number 2, आपने पेशेंट को प्लांटिग्रेड फुट दे दिया, चलने के लायक, यू आर सक्सेसफुल। शोएबल ब्रेसेबल फुट दे दिया आपने, यू आर सक्सेसफुल। फुट इन रेमिशन, जैसे आपने कैंसर को रेमिशन में रखा 5 साल तक, 6 साल तक, यू आर सक्सेसफुल। Remember this. So diabetic foot is worse than a cancer now. I don't know how many know. The already data has proved the highest mortality in the world right now, CA lung, CA pancreas, the way they have data is. The next line is CLTI. The next to CLTI is DFU with DFI. All are in the race. If we continue the same knowledge, they will be highest number 1 position and they will have highest mortality in the world. So whatever we are trying to know, the challenges are increasing day by day. The last slide is a temporary arrest. There is no cure. Please make these points very clear. Ulcer-free days are indicators of your success. If an endocrinologist, diabetologist in the center says that I have kept this patient ulcer-free for more than 5 years by excellent foot care, he is excellent physician in diabetic foot. That is how it is rated. Never blame diabetes. Never ever blame diabetes. We have to dig, understand the pathophysiology, what is going wrong in the diabetic foot. This is a gray zone. Nobody is interested in this area. But by the time many lectures will be over in this hall, you will be seeing a colorful history of this foot. Right now, it has started with the gray zone. Everywhere, there are a lot of failures. Though you could see, it has shown equal time. I am going to have a victory, but still you are not appreciating that. But I can show you in my last lecture, it is going to be a very colorful victory what this foot is going to have. Thank you. Thank you so much.